Dr. Lefkowitz, are you here? Oh, there you are. He's ready to go. Okay, another great friend of the foundation. He's done so much for us. He works at Memorial Sloan Kettering as the
Desmoid tumor
radiologist, especially in sarcoma, knows desmoids. I'd just like to ask my question in advance, because I found when I had my tumor monitored or read by the different radiologists every time, I got such different results. Oh, it really grew, or oh, it shrank, or it just grew this way. And I came to the point where I insisted on having the same radiologist read it every time. And I would send it back. I said, you agree? I asked in advance, would you make sure that Dr. So-and-so reads this? So it was consistently one person looking at the scan. Tell me if that's a good idea or not. But because I think it's something that a lot of patients end up, you know, we're measuring tiny things that might even be observed by not an expert like Dr. Lefkowitz. So just want you to cover that.
That is actually the last point I'm going to make.
Okay.
Presentation.
Where's the, here's the advance. Green button advances. We ready here? The, slide up there. Oh, I'm gonna go back all the way, actually. Is this, did you get to the beginning? Oh, here we go. Anyway, I'm going to discuss imaging of desmoid tumors. And the first, I just want to talk about the two imaging modalities of choice for desmoid tumors are MRI and CT. You can see on the left, that's an MRI machine. It's actually a very large magnet. It's a long tube, so if you're claustrophobic, you may have a little bit of problem because your body actually goes into that tube, and it's centered in the part of your body that needs to be imaged. And it's actually pretty good. It's fairly narrow, and the imaging times are long. I mean, it could be typically like a half an hour for our MR soft tissue protocols, and sometimes even longer. Whereas a CT, as you see on the right, is it's a much smaller tube. It's a little wider, but it's very short, and you go right through it. The actual imaging time itself is really in a matter of seconds. I mean, so it's not a matter of claustrophobia. However, as I'll discuss, CT gives off radiation, whereas MRI doesn't have any ionizing radiation. So MRI is also called magnetic resonance imaging. It uses changing magnetic fields while you're in that magnet to induce your parts of your body to give off radio frequency, or basically radio signals that are detected by an antenna, and then actually produces images of your body. And that does not use ionizing radiation. Whereas CT, the CT gantry, which is in that tube, kind of spins around you, gives off X-rays as it's turning, and then it receives the images. And the images to get them, you do need to use ionizing radiation. And just quickly, if you look at the electromagnetic spectrum at the bottom there, lower energy waves, like you get giving off with MRI, they're like radio waves. They don't do any damage to your body. Whereas, as you see down at the bottom there, X-rays are ionizing radiation, and they can actually cause DNA damage, which if you have a lot of them, there's a very low risk of causing cancer if they are used too often. Actually, anyway, so we're going to talk about the different sequences to image MRI. So there are the standard soft tissue sequences that we use at Memorial are T1 weighted, T2 weighted images with fat saturation, and T1 weighted images with fat saturation both before and after contrast. So the T1 weighted image is an image where fat is bright. Let me get this pointer and show you. So if you see over here, is this working? One second, sorry about that. Well, anyway, if you look at the, well, actually the cursor's working. You can look on, can you see that? You cannot see that. Is it working? Hold on a second. I saw it for a second. the top one. Oh, there it is. All right, so but it seems to be fading when I get to the screen. I think it's losing its, oh, there it is. So you can see the fat here is bright. This is intraperitoneal fat. This is subcutaneous fat, and there's also even fat in the bone marrow. Those are all bright on T1 weighted images. Whereas fluid is very dark. This is actually where the spinal canal in here, and there's actually CSF in there, which is fluid, and that's dark. And even muscle is always on the low side. As opposed to this T2 weighted image, where fluid is very bright, and because it's fat saturated, fat is dark. So you can see that fat in the subcutaneous tissues, in the peritoneum, and in the bone marrow, it's all gotten very dark. Whereas fluid is, look at the CSF here, the spinal canal, which is over there, is actually very bright, because that's why we do T2 weighted images, so to make fluid bright. And in fact, most tumors are also bright because they have a fair amount of fluid in them, and also muscles, which are just around over here, are just kind of intermediate signal. So we also do coronal images. We do axial and coronal images. So basically the same T1 and T2 fat saturated sequences. And then we also do pre and post contrast images, which are done with fat saturation to minimize the brightness of the fat surrounding the tissue. So when when the contrast is taken up in tumors or even just regular organs, for example, you can see like the liver here it's gotten brighter from the pre to the post, and the kidneys have gotten brighter because there's contrast that's been given, and anything that has a vascular supply will get brighter. That's why we use contrast. Now we're going to talk specifically about MRI features of desmoid tumors. So desmoid tumors, the most basic description, they're composed mostly of fibroblasts and the collagen which they produce. So when there are a high percentage of fibroblasts, in other words, they're active desmoid tumors that have the potential to grow. These are called cellular desmoid tumors, and they are high in T2 signal due to their high water content. And they also brightly enhance with contrast. Whereas when desmoid tumors have fewer cells and they're more collagenous, we call them collagenous desmoid tumors, and those are lower in T2 signal due to the lower water content that's in the collagen, and there's very little enhancement. And these tumors when they're collagenous, they're not going to grow as well. They're not technically going to grow at all, really. So just to point this out for everybody, start over here. Anyway, you can see the top arrow. Just use the arrows in this case. The top arrow is on a very bright area within that desmoid tumor. That's because there's a lot of cells in that area, a lot of fibroblasts, which are actively producing collagen. Whereas the dark areas on the bottom arrow, you can see it's pointing to a very dark area in the same tumor. That area has lost its fibroblasts and is now darker. And those areas potentially should not grow. That's why we talk about high T2 signal and low T2 signal for that reason. So here's an example of a cellular desmoid tumor. The right side image is the T2 fat saturated sequence, and you can see that the tumor is very bright because it has it's almost completely cellular, a lot of fluid. And on the T1 weight image, it's not so important in this case, but you can see it looks very similar to muscle. Okay, it's basically that in the same area where it's bright on the T2 weight image. So here's another patient with a mostly cellular desmoid tumor that has these characteristic bands of low signal going through it, which are very typical of desmoid tumor. If I saw this tumor on a young patient, I would say it's probably a desmoid tumor, even without knowing the histology. But anyway, on the left side image, the first image is actually the T2 weight image, and you can see almost that big bright area this is in the patient's gluteal region, the buttock. It's almost completely bright. So it's mostly cellular, but it has these dark areas, these very small dark areas, these like little circles and bands that go through it. Those are just small areas that just have collagen. So it has some collagen, but it's mostly cellular. And the post-contrast images look very similar to the T2 fat saturated sequence images because the fibroblasts and those areas enhance a lot too. They have a lot of, they do take up contrast. So here's a mixed cellular and collagenous desmoid tumor. On the T1 weight image, you can now see that the whole tumor doesn't look like muscle anymore. It actually has these dark areas in it, which are actually the bands of collagen. And And on the T2 rate image, the dark areas are also very dark, because again, mostly collagenous, and the cellular areas remain bright. Half the tumor is cellular and very bright on T2, and then half is dark, because that's where the is only collagenous. And here's an example of a completely collagenous desmoid tumor, almost completely collagenous. The T2 image that you see over there on the right, it's very dark, darker than anything else in that image. And likewise on the T1 rate image, because it's just dense collagen, it's also very dark. So the tumors that have no cellularity are dark on both T1 and T2 rate images. So I just want to discuss some treatment real quick and how that is reflected on the imaging. So as we discussed, here are some of the treatments that we use: is Sloan Kettering, doxorubicin, methotrexate, tamoxifen, sorafenib, and of course there are other drugs which we've discussed today. And sorafenib, of course, is the most common one we probably use. And then most recently we have nirogacestat, which is not yet FDA approved, but we've seen there's some very good results with it. So CT and MRI, both, you can follow tumors on either CT or MRI, but which both would show decreases in size. However, the MRI has the added value of showing decrease in T2 signal as the cellularity of the tumor decreases with treatment. And it's even been shown, or clinically we noticed that patients that have decreased T2 signal alone, even if there's not a significant size change, will have some improved symptoms. So just this decreasing T2 signal is actually a good sign of treatment. So this is a patient with a desmoid tumor in the upper arm area right here. And it's actually the lateral arm right over here. And so you can see it's this bright area, which is sitting next to the bone there on the pre-treatment T2 weighted images. It's almost completely bright. And then you can see, even if I don't point to it, you can see that area that's bright on the pre-treatment scan has now become very dark. If I get this thing to work, I would point it out, but I think, oh, there it is. This area right here is actually the treated desmoid tumor over there. It's much harder to see, but it is completely dark, which is an excellent treatment response. Even though the size, even though it hasn't resolved completely on imaging as far as the size, the cellularity has almost completely disappeared, and this tumor did not grow any longer. And the patient felt better also. Here's another patient on sorafenib, T2 fat saturated sequence, the baseline study you see over there. There's a lot of bright areas in it, although some darker areas that are not. So the whole tumor's not cellular. The cellular areas are here, the collagenous ones are there, right here, and the darker ones are collagenous. But after treatment, 10 months later, almost the entire tumor is now dark, indicating a very good treatment response. All the bright cellular areas that we saw originally, for example, over here, have now become darker. The dark spot right there. So here's the study. Here's a more recent patient. Was our nirogacestat study. It's an excellent response. We see the baseline T2 image. I'll show you the point the tumor out. It's this big mass right over here. This is actually located near the groin. It's in the lower aspect of the rectus abdominis muscle, as you can see over here. So it's very large. And that bright thing next to it is actually the bladder. So you see how large it is even compared to the bladder. And so 18 months on treatment, the size shrank significantly, and the T2 signal has also significantly decreased, which is an excellent response. Let me go back. Sorry. Now I'm going to just briefly discuss cryoablation. I know we already discussed it, but I just have a few things to add. So cryoablation, as discussed, was a method to treat cellular. Well, in this, specifically, we treat the cellular components of desmoid tumors using a probe to freeze the tumor and cause cell death. As mentioned, it's a treatment option for local control of extra-abdominal desmoid tumors, either as first-line therapy or as salvage therapy for patients who have progressed on other treatments, for example, after surgery or medical treatment. And one of the papers done at our institution with Dr. Gounder and Aaron Jerry show that there's long-term disease control comparable to surgery in patients treated with cryoablation. And the advantages are, of course, it's less invasive than surgery, and also you can avoid the systemic side effects of medical treatment. So I'll show you one case here. Sorry. So this one case, this patient, as you can see, this patient has this very large mass right here. That's actually the chest wall over here. And this patient was previously treated with medical therapy, but progressed and now has this big mass that's really bulging into the chest cavity and it's compressing the lung. So it's decided, the patient opted for cryoablation to control the intrathoracic component of this tumor. So as you can see, CT is used most often to put the probes in and to see where they're located. And so you can see these bright structures that are in that tumor there. Those are the cryoablation probes, as we discussed earlier, that you can put multiple probes in. And the first image on the left is actually the pre-treatment, and the second image is the post-treatment. And you can see how the lesion looks like it's got a lower attenuation. It actually is almost similar to water attenuation here. That's because that's the ice ball that's created. And you can actually see the ice ball while you're treating them to see that you've covered the entire tumor. So in this case, you can see the ice ball actually extends out into the chest wall here. And so it really did cover the whole tumor. It was a nice job treating this very large tumor. And then, so afterwards, we can see the follow-up MRI after ablation. And, we always expect some enhancement in the periphery because there's always some reactive soft tissue around this area of enhancement. But as long as it's smooth, that's always the expected post-ablation changes. It's actually your body reacting, some of the reactive tissue from your body that's causing that. But that's not the desmoid tumor itself. However, and those changes improve over time. However, 1 year later, you can see there's actually this nodule here. So that's actually not good. So there actually was a recurrence of the desmoid tumor in that one spot. But those can be treated again. In fact, the patient did have another cryoablation. You can see here that the probe was put into that tumor where we saw it was enhancing before. And we see now there's a nice ice ball there. And on subsequent MRI, there was no more enhancement at that site. So this patient was treated and did not get a recurrence after that. So it took 2 ablations, but it was treated a very large desmoid tumor. All right, so now I want to discuss, is it better to get MRI or get CT? So the advantages of MRI over CT for extra-abdominal desmoid tumors, those are desmoid tumors that are outside the body cavity. MRI has superior soft tissue contrast compared to CT because the tumor stands out very well against background muscle and fat, whereas desmoid tumors in skeletal muscle on CT often have a very similar appearance. It's hard to distinguish them. The attenuation is very similar. MRI, you can use T2 signal to determine the degree of cellularity. That's also helpful to assess tumor response. Whereas on CT, you really can't assess cellularity very well. It's hard to tell the difference between the cellular and the non-cellular ones on just a regular CT. MRI uses no ionizing radiation, as I discussed, but CT does have a moderate dose of ionizing radiation. MRI has less renal toxicity because the amount of contrast that you give is much less. And in fact, MRI can even be done without contrast in patients who have renal failure because you can still see the T2 signal. Whereas CT, you certainly wouldn't want to do a CT in an extra-abdominal desmoid tumor to assess it because it'd be very hard to distinguish from muscle. There are cases where you can do non-contrast CTs in intra-abdominal desmoid tumors, but those are different than the extra-abdominal ones. And lastly, gadolinium, which is what the contrast that's used for MRI, it's very rare to have an allergic reaction to that, whereas the CT contrast, although not that common anymore, is more likely to have a reaction, some kind of allergic reaction. So when should a patient get a CT for an extra-abdominal desmoid tumor? Some patients cannot get MRI because they're claustrophobic, as I showed that long tube. If you're sitting there for a half hour, some patients don't like that. And also certain devices are not compatible with strong magnetic fields of MRI. And those include pacemakers and certain other electronic implants in most cases. Some older aneurysmal clips and metallic foreign bodies in the orbit, for example, they can move around in the magnet. So you don't want to do an MRI if you have any of those, or you at least want to certainly get improved before you have an MRI for any of those conditions. So here's an example of what a desmoid tumor looks like on a CT. This first image on the left, I do have an arrow on it. You can see that there's you can see the mass here. You can see the difference between the muscle, but it's not that obvious compared to the MRI, which is very obvious. It's much brighter than the muscle with contrast. So that just shows you how much better an MRI is than a CT. And in fact, here's another patient with a rectus abdominis desmoid tumor. That's the abdominal wall. You can see this is very subtle. You can see some enhancement here. This is the tumor. The regular muscles here, hard to tell the difference, but on the MRI, you can clearly see it's bright on very bright on T2, and the muscle is much darker. So that's why you want to use MRI over CT with extra-abdominal desmoid tumors. So the conclusion is that MRI is a modality of choice for extra-abdominal desmoid tumors, including those in the extremity, the chest wall, the abdominal wall, and the pelvic soft tissues. But what about intra-abdominal desmoid tumors, such as mesenteric desmoid tumors? So intra-abdominal desmoid tumors are actually seen better in most cases on CT, better than MRI, because bowel and abdominal wall motion can often obscure the desmoid tumor. MRIs take a long time, and all that bowel wall motion can create an artifact. Whereas on CT, it's so fast that the bowel wall motion usually doesn't have a significant effect on the imaging. And also, we sometimes use CT contrast, which makes it easier to see the desmoid tumors against the background of contrast. And again, the other thing, so it's MRI usually is hard. It sometimes can be very hard to distinguish bowel loops from desmoid tumors on CT, because they can be bright, they can be dark, and they really can make. I'll show you images. It could be hard to distinguish. So, whereas on CT, again, they're much easier to see. And also, the mesenteric fat on desmoid tumors can look dark on, say, T208 images. And if you're following a collagenous desmoid tumor, which is dark, they can be very hard to distinguish. So here are some examples. So this is a CT with, there's a desmoid tumor. You can see it stands out nicely from the contrast in the bowel loops around it. Whereas on the MRI, same, there it is. It's much harder to see. It's actually this thing here, but it looks, even to a radiologist, it can be hard to find. I mean, it looks similar to some of the mesenteric fat, which is dark. And even the large bowel loops which have air in them are dark. So, depending where it is, it could be hard to pick it out unless you know where it is already. And the fact is, now that we know where it is on the CT, it's easier to find it on the MRI. Here's a contrast MRI. It's the same CT I showed you before, but now we gave contrast. So there it is now, a little easier to see on the contrast part of the MRI. But again, it does look similar to some bowel loops. So unless you know exactly where it is, especially if it's a smaller tumor, you may not be able to find it so easily. There's another patient with a CT of there's the desmoid tumor there. It's nice to see it around these bowel loops. And there it is on the MRI. It is easy to see on this MRI, but it is dark. And if you weren't aware that he had a desmoid tumor, he or she had a desmoid tumor, you could possibly mistake it for some other structures, such as some of the bowel loops over here, which are dark. Now I'll show you some more difficult cases. This is actually, you can see that big mass there on the first scan. That's a huge desmoid tumor in the mesentery. It actually was easy to see on MRI because it was so large. But after treatment, you can see where those arrows are on the second scan over there. The second image, you can see now it looks like more of a crescentic shaped structure. It's much smaller, but you can still see it pretty easily on the CT. However, on the MRI, so in the CT, I have the arrows where you can see it stands out nicely against the bowel loops, against the adjacent vessels. But on that MRI, if you didn't have that CT to show you where it is, I'm pointing the arrows pointer right now. It's really kind of hard to pick out. I mean, you could easily mistake that for mesenteric fat, because fat is dark on T2 fat saturated sequences, and the desmoid tumor, because it's almost completely collagenous, is also dark. So depending on the degree of cellularity and collagenous component, certain structures could obscure the tumor on MRI. And here's another, same patient with the gadolinium, which is post-contrast, also hard to see. And then this patient was followed 5 years later with MRI. We're still fine with MRI, but you can see that the arrows in that right side of image are where right here is where the tumor is. Again, very hard to pick out. If you just look at this without knowing where it is, it's really hard to pick that out. But having the CT as a roadmap, you can see where that desmoid tumor is. And I'll discuss why we are doing MRI in these patients, even though it's easier to see with CT. And because you really have to balance the radiation risk for CT versus MRI. So as mentioned before, CT does use ionizing radiation. And even though the risk is very low, I mean, I've seen some studies show 1 in 1,000 chance getting cancer for one CT, but there's another more recent study that shows a 1 in 10,000 chance of getting cancer from a single CT, which is very low. But the problem is the risk is cumulative. So if you have 10 CTs, that multiplies the risk by 10 times. So the problem is, if you keep on having, people with desmoid tumors are often followed for years. And many people are young patients. So we don't want to keep on exposing patients to CT radiation over and over. So that's why we do MRIs. But I think one strategy that's good to employ, which we do at MSKCC, if a young patient has a desmoid tumor, an intra-abdominal desmoid tumor, we will get a baseline CT as a roadmap to see where it is. But then most of the follow-up scans are done with MRI to reduce the radiation risk. But it's once you know where that tumor is, once you can road map it with that CT, then it's easier to follow an MRI. So I think that's a good strategy to use for intra-abdominal desmoid tumors. Lastly, I want to talk about tumor measurements. And so there's many methods we can use to measure tumors. One is the RECIST, or the one-dimensional tumor measurement, which we really only use during the patients on the IRB protocols, because that is the standard measurement, is a one-dimensional. The longest axis of the tumor is what you use to measure these for RECIST measurements. The WHO, or the two-dimensional measurement, is what we would use on a standard MRI or CT just to follow up desmoid tumors. Of course, it's given 2 dimensions is more accurate than 1, and even we often give 3 dimensions as well, 3 different measurements, and that is even more accurate. I mean, of course, the most accurate way to determine how big the desmoid tumor is by using volumetrics, which is really very time consuming. And of course, we also have T2 signal, which we use on MRI, which is a very good method to evaluate. So here are the examples. So you can see in that first slide on the left where you have a very bright desmoid tumor, which I showed earlier. It's a cellular desmoid tumor. You see the measurement that I put on that was 28.8 millimeters. And then this patient was on sorafenib, I believe. And after a few years or a year or so, the tumor has clearly decreased in signal. It was a great response because the cellularity has completely disappeared. But if you look at the measurement, it went from 28.8 to 27.0 or 27.1. So it's really, that's a very small change in size. So by RECIST criteria, it's called stable disease. It wasn't a 30% decrease to call it a response. However, clearly there was a response by T2 signal and the patient felt much better. So I think medically, from a medical oncology point of view, I think this was a success, but just from a RECIST point of view, it was just stable disease, which is also a success, but not as good as it really should have been a response. So here's what it would look like with 2 dimensions, that same tumor. If I just measure the short axis, now I added that extra measurement right over here. This is the short axis measurement, which is not we don't use those for the RECIST or the IRB protocol. It's just the long axis. But in this case, the short axis went from 27 millimeters to 17 millimeters. So that's actually a nice change in size. That actually is more than 30%. But of course, that's not what we use on our RECIST measurements for the IRB protocols. That would you don't use the short axis, you use the long axis. So it doesn't take into account the short axis dimension, which is really very helpful. I mean, it's more useful than just having a single dimension. But most radiology reports, I'm sure almost all radiology reports have 2 dimensions that they report in a standard report, even though it doesn't actually qualify for the protocols. And in this case, also, again, the signal decreased a lot, which is important to mention also. Finally, well, you can do 3 dimensions. It adds some extra information. It's simple to do 3 dimensions. This is actually, you see the 2 dimensions on the axial image, which is the cross-sectional image, and the image on the right is actually the coronal image, which is kind of the craniocaudate. So that would be measured in this plane. But now, volumetric measurements, ideally, are the best way to measure a tumor, but you'll never see that in a report, or almost never, because it's extremely time consuming. It's used in research. We do use volumetrics in research, but you have to get someone who will outline the entire tumor on every section. So you can see here, that's the first section. There's another section here. You have to get in all those crevices too. You can't just make a circle. So, I mean, some tumors can have you could be on 20 different images and you just have to outline every one. So extremely time consuming, but not practical for a report, but good for research purposes at this point until the technology gets better. Once you've outlined it, you can do everything. It can tell you the volume, it can tell you the T2 signal. So that's once you get it worked on, then the computer can do everything for you. One last point I'd like to discuss is the tumor measurement variability, and actually, just to make it simple. So this is a desmoid tumor that I read a few times, but you can see it can be measured in 2 ways. You can have this first measurement just has the, well, you can see that green part goes only to the main bulk of the tumor is measured here. You can see If you get this on one more time to show you this. There it is. Oh, so you see it measures the main mass. But some people may choose to take this all the way out to that little tail that sits out there, because that is part of the tumor, but it's only a very small part of the tumor. So depending on, the tail is so small. Some people may choose to measure the main bulk of the mass, because that's what's going to change more. But if you measure it out to the very edge where the tail is, which is also correct, you can see how the same measurement can vary by quite a bit. I mean, it's went from 27 millimeters to 39 millimeters. So you have to make sure when you measure between scans from one scan to the next, you need to use that same edge, the same spot that you measure. You can't start switching. And the problem is sometimes when you get different radiologists, they'll choose different spots. So that's what you have to watch out for. You have to make sure, if I'm reading someone else's scan, I will either use the edge that they used, or I'll remeasure both scans myself and say I remeasured on the prior because maybe I didn't like the way they did it. So you just have to make sure you're consistent between scans. And I know that creates problems if you want to go back to the beginning of the imaging, but from the baseline when they started therapy. So there are issues involved with measurements. How should we do them? And in fact, one other problem here, this is a patient, this is actually the coronal image in a patient's extremity. And you can see the measurement on this first one is 125 on the left. On the right, it's 104. So there's a somewhat difference in measurement, but actually it's the same tumor on the same day. The difference is it was one slice different. And on these coronal images especially, the tumors can change moving over one slice, the tumors can change pretty significantly. And even from scan to scan, sometimes the coronal plane, the sagittal plane are shifted a little bit by the technologist, and it can change, the size can just change on the coronal image alone just because of the scanning the plane. So that's why you should always measure the axial planes. It's more reproducible as far as one scan to the next. But even on coronal images, if you see differences, you really have to, the radiologist really has to be careful that those images, that those differences in measurements are real and not just because it's a different slice of the image. And that's all I have to say. Oh, actually, I'm gonna have to ask my interventional colleague this, after cryoablation, how long does it take to see the collagens change? Do you want to answer the question? I mean, right.
You get much more of just ablation, collagen change, and reabsorption. If you got it, one of the effects when you do vascularization going through it. So the cryoablation can cause thrombosis, the vessels support it, and that will kill part of the tumor if you actually directly ablate. In those areas, you can sometimes see some collagen change due to hypertension. But for the most part, they just actually manage to step in the inflammatory chain that slowly shrinks down and disappears.
Yeah, so I guess sometimes I realize maybe it's just regular scar tissue you're seeing, not really the collagenous portion of the desmoid tumor after it shrinks down. It's hard to tell, right?
Right, yeah. So some of it could be hemocidin too. So the tumors will leave a little blood that goes into that pocket. So sometimes we get hemocidin and heme blood, serum. We get like a deposition of iron along the wall. That can be darker too as well. But yeah, and when it really shrinks down, you're right. It's just like normal scar tissue formation.
But I guess maybe the question is, and to be honest, the results are really immediate. I mean, as soon as you freeze that tumor, you're really kind of killing. So I guess it's kind of a moot point when it becomes collagenous, because it's really the cellular component is being treated, and it's already at that moment it's already been treated.
Yeah, so there's mechanical disruption to the binding of tissue, components of apoptosis, cellular apoptosis. But usually the shrinking down takes years. You may see a little bit of life. It really does just do it. As you were seeing on the chest wall.
Yeah. Yes, over time that happens. So thanks for helping out there.
So what would you say on average is the typical margin of error on the measurements of these tumors?
I mean, when I do it, I try to keep it. I keep it with. I actually try to get. I try to get to. I will. The truth is, if I don't get to the millimeter, I double check to make sure it's not done. Because if it looks the same to me and I'm getting changes, I really just check to make sure it's perfect. It really depends on the radiologist how. I mean, they really just have to be thoughtful and think about, are these changes real or not real? You can get it, I mean, you can, I actually look at the image on the full screen, I double click and blow it up so that I can see the edges very close. Some people may measure on these, people have 4:1 on the screen, or sometimes even 6:1. Maybe you can't see the edges well, but I make sure to really blow these things up and really get the edges. So it matters, depends on the radiologist, but I'm sure you can have, you can certainly have 20% errors if they're not careful, I think. I mean,
Or you have different readers.
yeah, different readers, but right, but yes, different readers, but I always go back and check the old measurements to make sure. I don't just use measurements from the old person. I use my measurements, and if I see the person didn't measure exactly like I did, even if they use a different axis for measurement, I just remeasure, because it could change just by rotating the axis of your measurements a little bit, enough to perhaps. And again, if your patient's on a protocol, sometimes it's enough to put them over the top of progression. So you got to really be careful.
Okay, thank you so much.
You're welcome.